from the College by the Lake, Coeur d'Alene, Idaho. Local, regional, national, and international guests discussing the issues and topics affecting the way you live are on Forum, the North Idaho College Public Forum, with your host and moderator, political scientist Tony Stewart.
Welcome to the fourth week in our 5-week series entitled Universal Health Coverage in the United States, Can We Do It? On program number 4, we're going to be discussing the area of health care that many of you may not realize is the most impacting from the number of people involved and financial impact. We're talking about the area of accidents and the question of trauma. We could not be more fortunate than we are today to have such a qualified person that has been on our campus to speak during this symposium and to be on this program. I welcome Dr. James Nania, who is the medical director of the Department of Emergency at Deaconess Medical School or Hospital in Spokane, Washington. Dr. Nania serves as chair of the Washington State Governor's Advisory Committee on Trauma. He was appointed to that position by the past governor of the state of Washington, Booth Gardner, and has been reappointed by the present governor, Mike Lowry. Our guest is also the medical advisor to the Lifebird Air Transport and medical program director to the Spokane County Emergency Medical Services. He is also chair of the Washington State EMS and Trauma Care Steering Committee. Our guest holds a BS degree in the field of zoology from the University of Wisconsin in Madison, and he has a degree in the field of medicine from Loyola Stretch School of Medicine in the state of Illinois. Our guest also did internal medicine internship at St. Francis Hospital in Evanston, Illinois, and also emergency medicine residency from the Lutheran General Hospital at Park Ridge, Illinois. And we're very pleased that he lives nearby in Spokane, where he's been for a number of years. Dr. Nania, welcome to our program. It's very great of you to spend so much time with us today on our campus and on this program.
Thanks, Tony. It's been real nice.
And I'm very pleased to have our regular panel members to join in the question of our guest on this very important issue of medical care. First of all is Janelle Burke, who is an attorney in the state of Idaho, and next to her is Steve Schenck, who is the Dean of College Relations and Development at North Idaho College, and I shall ask Janelle to commence the questioning.
One of the things that most of us are concerned about is getting that inevitable call that something might have happened and that we have to go to the emergency room. Every day we pick up the paper and we see a number of accidents have occurred. What is an emergency room in a busy hospital like at your hospital, and what kinds of numbers are there now?
Well, I guess across the nation there's been a mushrooming of the number of visits to the emergency departments of America for a variety of reasons. Most often still for emergencies, minor and major, from earaches to severe broken bones and life-threatening crises. And yet some of the growth in the business has been related to the lack of primary care available, the lack of physician-patient relationships that are long-term. In addition, there may be a factor of convenience in that someone develops a problem, they want it checked. And to make an appointment and rearrange tomorrow for that is not always, I think, most desirable by many of us who like to get something taken care of when we can at a time that's convenient for us. So all those factors have mushroomed the census for emergency departments. Among Spokane's 4 community hospitals, and this is excluding other urgent care settings where there are many other similar visits for minor problems, there would be approximately 110,000 visits a year.
That's a great number, it seems to me like. How many of those would be really serious, and how many of those are life-threatening? And how many of those, do you divide them in that kind of category, or do you not indicate them that way, but something that's fairly serious?
Well, actually we do, I would think, although I can only speak for my own shop, but we do a statistical analysis of the severity, or what we call acuity, of the care in cases. And I can only give you an estimate, but I would think only 25% represent major emergencies that threaten life or limb. The majority of care is for meritorious but minor emergencies, lacerations that need to be repaired, and it's no good to wait 6 hours. You get a less desirable outcome. A broken bone that needs to be cast, maybe not even straightened. infections that are better treated promptly than left to go another day. But simple things that at the lower end can be seen in the doctor's office in some cases, if that office is available and open. So the spectrum is broad. We're joked as being maybe 20-minute masters. We need to know a lot for 20 minutes about a lot of things, but after that we often will pass the care on. It's not quite that simple, but the breadth of our experience is great. The depth of it is not so great for some things.
Now, I want to explore one little other area before we get into more cost questions,
Sure.
but that is how many of those people arrive on their own as compared to arrive through some kind of an ambulance or lifebird or that kind of thing. Do most people come on their own?
Oh, sure. I think it would be a similar figure, but even in that we often get some significant emergencies by private vehicle, sometimes unfortunately. I would think that 85% of our patients would arrive by private vehicle or other means.
And so now let's get into a little bit, just to set the stage for the rest of the program, what the cost might be to this. Emergency room care must be more expensive than going to see your physician in his office.
Not true.
Is that right?
Well, the allegation, and there is some truth to it, that is the case, has been kind of conventional wisdom for years. But in part, as the spectrum of care has expanded to include many minor conditions, almost all modern emergency departments have differential charges for minor cases. And indeed, in Spokane, at least 3 of the facilities have urgent care treatment areas, where not only is the facility charge less, the physician charges less, and the rates may indeed be competitive. Part of, I think, the frustration for those of us in emergency practice are going to the emergency department's expensive. We must reduce the numbers of people going to the emergency department. That's almost conventional wisdom too. Why is it expensive? And probably the biggest reason it may be more expensive than routine office visits is the overhead involved in the 24-hour capability of a comprehensive critical care facility. If you have to have the equipment available to treat a life threat, if you have to have the training of the staff available to treat a life threat, if you have to have all the diagnostic tests, laboratory backup, x-ray capability, that's a far broader spectrum than the doctor's office. And it has to be there 24 hours a day. And hence the increased cost in some cases, particularly for cases beyond the very routine, is part of the way to pay for the capability to have the comprehensive spectrum of care. And therefore it's one way for a community to pay for that capability 24 hours a day. You can ask, well, how many do you need? And that's a fair issue to ask. For traditional reasons, most comprehensive medical facilities have developed emergency departments to initially treat and stabilize patients that arrive at all times of day. So in part, it's part of a frequent format of fixed facility or hospital organization of healthcare that also contributes and is necessary for the hospital function.
Steve Sheen.
I'd like to follow up on something you just said. Earlier you talked about the fact that in many cases with acutely ill or injured patients, you do the original evaluation and stabilization or treatment and then pass that patient on to a specialist of some kind. But just a second ago you also said that you're staffed and set up to handle patients 24 hours a day. And my perception of hospitals is that most operations and most of the specialty staff would probably be available during the day, whereas at night, when in fact many serious accidents, especially violent acts, take place, to get to the point of my question, do you have the same backup in your situation at 3 o'clock in the morning that you would if somebody comes in critically ill at 3 in the afternoon?
That's a good question, and it relates to, I think, a benefit of emergency departments and hospital-based emergency services. There's a requirement among significant-sized hospitals for the attending staff to provide call coverage. Those who utilize the hospital for their inpatients, for their surgeries, for their medical care of patients in their own practice, are required to provide some degree of coverage for the emergency department. The call list that is generated may be complete, as it would be at a tertiary care facility, a big hospital. It may only involve several specialties at a smaller facility. But it is necessary and by law has to be available 24 hours a day. And that's how our call list is established. It's a rotation for 24 hours. And the same degree of specialty coverage is available 24 hours. All our other obligations and a lack of coordination between the obligations that physicians might encounter elsewhere, other emergencies, without planning and coordination can conflict, sometimes leaving you without all manner of coverage you would hope to have.
Let me follow up again a little bit on the staffing question. If my math is correct, you said 110,000 treatments, visits to emergency rooms.
That's a good estimate.
Among 4 hospitals in
Yes.
the course of a year. I think that's about 250 a day. Does that make sense? About
But you're going to get me on the math. It should be at least that.
it's probably more than that. I had to do it in my head, so I assume 400 days in a year, which is.
No,
But my point is,
like,
how big is your staff? How many physicians and other emergency service personnel do you have in your hospital?
well, again, I can't speak for all the hospitals in Spokane, but those that are seeing a volume, a lion's share of that volume, which would be the 25,000 to 30,000 range, are typically staffing with a single physician 24 hours a day and approximately 12 hours of staffing with an additional physician. In addition, there is staffing at least one facility in Spokane with physician's assistants who can be very helpful in the initial evaluation and treatment of patients. And that's one of the trends in the business. In addition, the nursing staff, typically in an emergency department, is capable of more initiative, perhaps greater depth in terms of patient assessment, so that often a veteran emergency nurse will give you clear direction as to what's wrong with the patient and what you should do now.
Thank you.
Dr. Nania, one of the purposes of this 5-week series that we have, certainly it's the main purpose, is where are we going with health care coverage in the future? And of course this is a national debate taking place with the President and the Congress. And I was just overwhelmed and also very satisfied with the information I received from you today, in the sense that it's very important for us to have the facts before we make certain decisions. And I would like for you to educate our viewers to the same kind of information that you gave today. If you would just walk us through the idea with the modern technology we have, what we're doing to ourselves with accidents and violence, and then this whole question of maybe new priority of how we're going to spend our dollars, both in health care and in some other areas that we may be required to divert some funds. You know, we hear about, or I had, what cancer and heart trouble and so forth cause. And I know that's a very general question, but would you do that for us, please?
Well, sure, thank you. And steer me straight if I get off the subject. But you were kind enough to allow me some liberty with the topic today, based upon the business I know, or aspect of medicine I know, and recognizing it's a broad field. And a particular interest of mine and involvement of mine has been with injury. And I think the point we tried to make today, that if you look at the historical perspective for mankind in the species, again, whether you look at 7 days as a creationist or 4 million years as an evolutionist, there's been changing trends in mortality, those things that claim the life of our species. And there's been a rather remarkable transformation in the last 100 years, where we have doubled the normal lifespan of man. There's plenty of evidence that for the vast majority of our existence as a species, that your normal lifespan is 45 years. Now, there would have for a long time been some singular examples of surprising longevity, as there are today. But most people didn't go very far beyond that, and there's plenty of evidence for that. Well, by virtue of nutrition and health care and a wealthier society in part, people are living twice that, as we well know. Therefore, the diseases that affect individuals have changed in terms of their many of the diseases we have focused on in recent years are the disease processes that affect those beyond that historical lifespan of the species. Most of the cancers and most of the heart disease, for example, which claim actually the most number of individual lives in the United States, occur after that time frame, the 5th, sixth, and seventh decade of life. And they have clearly received for a variety of reasons, not the least of which I think is that they affect those who have the most to say about things in the United States of America, have received the most resource, research, and dollar contribution. On the other hand, perhaps the most needy and deserving area is the area that relates to premature death and disability. For no one gets out of life alive. And in my practice, and I think for most of us, we would recognize a death that occurs early and unexpectedly is the most tragic of circumstances. We expect our children to grow up and have their children. And when we see a child who doesn't get a chance to do that, who has lost his life or been permanently disabled by a preventable cause or by a lack of treatment, everyone will recognize that as an expense beyond just the dollars to society. Although again, the expense in dollars is awesome too. For the young life lost does not become a productive member of society, and or the young life disabled forever will utilize resource for perhaps another 40 years. Because we travel on our highways in automobiles, fly through the skies in airplanes, because our workplace uses a lot of complex technology and machinery, because we have modified topography to include a lot of ladders and elevations and heights, because when we recreate, we do dangerous things at high speed like skiing, jet skiing, water skiing, and alpine skiing, and all other kind of very much fun but somewhat dangerous things, we've seen a mushrooming of the incidence of injury in the civilian sector. We learned about it and learned how to treat it in the military theater. You know, the history of emergency care and pre-hospital care was born in the battlefield. But there is literally a battlefield in the United States of America every year with an annual death toll in excess now of 140,000 from injury. Our highways alone accrue a death total almost equal to the entire Vietnam conflict every year. And yet, to some extent, because this is sneaked up on us, we fail to emphasize it or treat it like a disease. We have accepted it with euphemisms like, well, accidents happen. And you can't discuss this epidemic of violence and injury without alluding to the use of alcohol in our society and the fact that we have a legal drug that impairs judgment and coordination. And if you sprinkle that into dangerous means of transportation, occupation, recreation, and a lot of firearms, which I didn't mention, the fact is that this greatly magnifies the unintentional injuries that result. By any traditional medical measure, injury in America is an epidemic of tremendous proportions, costs our society $157 billion a year about, much of which is preventable, much of which is treatable, much of which goes unprevented and untreated because we put far more of what dollars are available to other aspects of medical care. It's not just insuring everyone and providing universal access. It's not just controlling costs. It's what do we spend that healthcare dollar on that's equally important. And I would submit to you that disease and of any kind that affects our youth and results in a premature form of death and or disability is the best place to put your dollar to reduce not only costs but human suffering.
You were so eloquent in presenting what the problem is, and now in dealing with that, it comes to my mind, and correct me if I'm really off base, but one of the problems is it not there's a lack of awareness to the statistics that you're giving. In other words, do we need to engage in a rather in-depth education to this area of health care as part of the solution?
Well, absolutely. I think I've always, to the extent I've spent a fair amount of free time involved with the process, has been the conviction that if the facts, basic facts were known, if the average American were presented with the numbers of death and disability for different diseases, their age of onset, the cost of intervention, that they would make they would reorder our current healthcare priorities and refocus what we spend our money on. They would say, well, I can save 8 children for that dollar, and yet I might use that whole dollar up treating a very severe disease late in life that it would be nice to do, but if we don't have an infinite number of dollars, we have to make some choices. I think if the average citizen, and if through our formal educational process we emphasized in a regular curriculum health care and made every citizen responsible for their own to some extent, and made them aware of how to live safely and how to benefit their fellow citizen should they be there when that person becomes sick or injured, we could save a fortune and we could prevent a lot of tragedy. And I think that's one of the roles of education in America that has been pushed to the side, in part as a responsibility of the government, but also the medical community in not more vigorously advocating for that role.
One final point I have before I go back to the panel, and I was really impressed with the panel member this afternoon, and I know him well, and he's zeroes in on those kind of points. And if you're going to also lobby for the proper, what is considered policies or public laws that one may need or funding, he said it's very hard to rally a group to lobby saying that I will sometime in the future be a trauma patient or I will have the head injury. So in these other cases, individuals can get support groups and start working if they have already experienced something as cancer. Is that part of the nitty-gritty problem?
Sure, that was a good point. I think someone else said, well, I remember when I was immortal, age 17 to 26, before I ever had a backache or saw something happen to someone I knew that they couldn't fix. And the fact is, our youth, and I've joked that part of the problem with our process as we've dealt with injury in Washington State and our plan for a state trauma system is we didn't have any 8-year-olds involved in the process. Fortunately, we had some good adult advocates for 8-year-olds, I think. But the age groups most significantly affected are prior to the point in life where they're enfranchised financially, where they have reached the points in their communities where they have authority and power. And particularly, of course, in the case of the children, they're dependent upon the adults to speak for them. And the adults have been not entirely, but disproportionately preoccupied with other causes.
Thank you. Janelle Burt.
I would like to ask a series of questions on illnesses and dangerous accidents that might occur in the home, violence, that kind of thing. Let's start with violence, actually, and talk about what kinds of violence presents itself in emergency rooms most often. Is it the gunshot wound, or is it other kinds of violence, more battery-type kinds of incidents?
Without question, I think, and much of it does come from the home, and much of it is related to some of the fundamental ills in some segments of our society, sprinkled throughout all of our society, maybe. We see a lot of domestic abuse, and I think we see more of it now. And I don't think it's just because people come forward. I think more of it quite likely goes on, and there's some statistical evidence for that. We certainly see more child abuse. The lack of strong traditional family role, to some extent, has got to compromise the environment, and to some extent has got to promote physical conflict. That would be my prejudice. We see a lot of people punching people, and very unfortunately, and most unfortunately now, we're seeing more people intentionally injure others with knives and guns. I had never seen an intentional gunshot wound to someone under 15 in Spokane for 14 years. We had 2 at my hospital in September. Kids 13, 1 dead, 1 permanently vegetative. So the spectrum is broad, and it strikes at the heart of our society in terms of what problems we have. The role of drugs and alcohol is undeniable. The lack of a regular family is often present. Unfortunately, the young adults, and too often now the children, are the victims.
What do you think we can do? Is it education? Is it getting into the schools and talking about what do you do to prevent these kinds of things from happening? Because certainly that's a preventable thing, isn't it, in part?
Well, again, I think if we talk about violence in America, and in particular intentional violence inflicted by us against ourselves, we get right to the fundamental societal woes in what can be done about them, and it's a very complex issue. If I could recreate a traditional nuclear family, not that we should be exclusive in that regard, there are fine families with single parents, fine families where grandparents raise grandchildren. There's a lot of possible varieties. I guess if we could create a loving family environment by legislation, a lot could be done to limit it without question. Short of that, I think our best avenue is through the educational process. Our schools increasingly are providing support for the education and development of children who might have been getting some of those things in the homes years ago, but are not now. And from Head Start programs to hot lunch programs to education regarding good conduct and behavior. I think my own children's elementary school does a great job in encouraging people to be nice to other people and non-physically enforcing that it's not good to bother other people. I think there's a great avenue for opportunity there, and I think it's, again, one of the most important things we need to be doing, particularly because of the magnitude of the ills we face and the resultant premature death and disability that's been generated. And I would submit it's perhaps more important than some of the traditional aspects of the curriculum that we teach.
We have less than 2 minutes, Steve.
A quick final question for me then. The overarching theme of our discussion this week has been national health care. How would a national health care policy affect emergency medical care?
A national health care policy depends a lot on what it looks like. Very much a part of it ought to be to guarantee access of all citizens to life-saving care and to make sure that they are not economically overly burdened by the results of receiving that care. National health care shouldn't interfere with access to emergency medical care, and in generally should improve patient access to all levels of primary care. Should make it easier to go to the family doctor. Should make general medical care more accessible, and should and must address prevention so that we live healthier lifestyles and avoid having to have a medical system that does a lot to focus on trying to fix problems that were accrued over years and could have been prevented if we'd been taught to be more healthy from the start.
On that note, I have to interrupt Dr. James. We are so pleased that you were here on behalf of the panel and staff. Thank you for being so helpful and informative during this interview.
Thank you, Tony.
Ladies and gentlemen, I know that you have found this program most informative, and I would like to invite you to be with us again next week, and we will do part 5, the final week of this subject of universal health coverage. Until then, please have a good week. I am Tony Stewart.
The North Idaho College Public Forum was videotaped live from the studios of Instructional Technology on the campus of North Idaho College for viewing at this more appropriate time. We invite you to join us again next week for another all-new edition of the North Idaho College Public Forum on this public television station.